lotion. But would you like a bolster?
Oh, sure. Let's do that. Where's my bolster?
You're slacking.
Okay, when I go to add my lotion, I want to make sure I've got lotion on my hands. The thigh is relatively large chunk of meat, so I'm going to need, say, a medium amount of lotion. Like the back, you always have to have a lot, right? The arm, not so much. Thigh, medium. I always introduce my forearms because they're warmer, they're dry, and then I spread the lotion, and this is just Swedish, making sure I'm spreading the thigh, gliding up around, following the natural curve of the body, in line with the drape. Folding, it's a really nice Swedish warm-up. It's done with the bony palm, press down, lift up, press down, lift up. As I get higher on the thigh, down here, my hands are right beside each other. As I go higher on the thigh, they're not aligned, so that I can get the visible thigh of the boy in the drape. Make sure I get the knee too. Any work I do around the knee is vertical, up and down, not side to side. Okay, now, Dr. Yu's thigh and knee are pretty well aligned, but you guys have all had that client on the table who you undrape and their whole thigh is completely laterally rotated, right? We don't want to do deep tissue work in this position because we're realigning fascia. We don't want to do that in a misaligned position. We don't want the body to get more comfortable in this position than it already is. So if that's the situation, the bolster makes this way easier, but you can do it without. I bring my hand under the thigh, I'm at the bolster, so I'm nowhere near the no-no zone. I lay my other hand on top, so I'm touching my own elbow, roll, sweep. Once I do that, their leg stays where it is. So again, glide under, roll, and sweep. If you do not sweep, it will not stay. I'll show that. Boom. See? You can roll it and sweep it. That's what repositions and holds it in position. And if you do that smoothly enough, it just feels like you're just doing Swedish. Cool. All right. Speaking of Swedish, most of you then begin with some sort of deep effleurage, typically using your ulnas. Yes. You can use palmar, deep palm. So I'm using this bony palm. If I lean in, I can do this while protecting my wrist. Inside, I'm not going to get nearly as much of this because, again, going in the inner thigh, I'm going to be really limited on location. My ulna blade is always going to give me better work. I do come across the knee, but I don't apply pressure until I'm on the muscle on the other side. My direction is kind of a 45. The more I press across the body, the more pressure I'm giving. But I'm slowing down. The more I face the head, I'm going to go lighter but faster. If I keep about a 45, I can balance my pressure versus my speed. If I have my elbow bent, I'm more focused on the outer thigh. On which muscle? Vastus lateralis. When I come back with the next arm, I'm right in the center. Again, this is just like the back. If I come right over my shoulder, I maximize pressure. If I fall back, I increase speed. I can moderate my pressure, my speed by my angle. I'm right in the center of the thigh, so my primary focus is which muscle? And then deep to rectus moris, vastus intermedius. So I'm going to follow this guy up, and if their underwear line is high enough, I'll come up until I feel a bony attachment point.
You're lightning at that point, right?
My pressure's pretty much the same because I'm only just barely feeling it. I'm not right on top of it.
Okay.
I will come back to that in a moment, but if I was just doing a firm, relaxing Swedish, I would come up here and then I would just go ahead and do my work. But I can also, say somebody has lower drawers, I can just, the back of my hand, I can just palpate the outer thigh and the pelvis, feel where the ASIS is, and come in right below that ASIS. From this position, I can work the attachment at the ASIS. I'm on the tendon for that. So here's the SIS. I'm on the tendon that attaches at the S, which is sartorius. Makes sense. S is at sartorius. And then end up right over the attachment for the AIIS, which is the attachment for rectus. So I'm in this position, I end up on the tendon of one and the attachment point of the other. Just applying, like we just think, consistent themes for your therapy across the body. Typically when I get an attachment point, I usually start with just compression. That's what I'm doing now. And then I usually do some sort of friction. I can do friction here by sawing across. I can do downward friction or like a pry bar technique. We've had those across the body by bringing my shoulder forward, which presses and lengthens the tendon down. Back to the medial thigh, come back to my forearm. Notice I'm bracing the thigh with my outer hand, because if I don't, I'll just roll the leg. By bracing it, I can then bend my elbow and use my ulna on the medial thigh. Now when I get to the drape, I do tend to lighten up and then just Swedish out of it, but it can be a very nice deep drape there. You can also come up and use another tool like a soft fist, but you have to make sure you're bracing that thigh. You're just going to brace it against the table, not just the bolster. And I'm not getting full extension with my shoulder there, so my pressure's not going to be outrageous, but some of you like to use other tools, soft fist and things. You get maybe a little more palpation.
What do you want me to read?
We did the ASIS saw. We're ready for patellar strip.
Alright.
Okay. Thank you. Good job.
Oh, I'm paying attention.
Oh, that was it. Patellar strip.
Alright, patella strip from
Okay,
the top
thanks.
patella.
All right, around the knee. We got a lot of knee attachments. I know you guys were palpating them this morning. First of all, one of the things that was not on your slides because it's back from the skeletal system is you got the ligaments that cross the sides of the knees. Remember what the letters are on the inside? It's cafeteria for old people. MCL. Okay. MCL, medial collateral ligament. LCL, lateral collateral ligament. Okay. It's not that hard. Medial lateral, because there's two. They're lateral, they're on both sides of the knee. They're ligaments, they connect bones to bones. All right? Generally warming up the knee tissue, ligamentous structures, joint capsule, drawing blood into the area. Coming down from the sides of the tibia, stripping up to the femur. Just got just curved fingertips and just stripping from bone to bone. Bone to bone.
We were talking about ACL and MCL injuries this
Yes.
morning.
Uh-huh. ACL's inside the knee.
Well, whatever.
LCL,
I might have said
LCL.
PCL.
Yeah, I think
Oh,
that's you did say that.
Yeah.
also inside the knee.
Yeah.
Is that gonna help with people who are like somewhat recovered from their injury?
Well, you've got four major ligaments here. You got MCL, LCL. Inside the knee, if you cross your fingers and lay them in front of your kneecaps, that's your ACL and your PCL. They're inside the knee. So when people tear their ACL, they're actually tearing a ligament in the knee.
So we
I
can't do
got the
anything for
inside
that.
of my knee replaced, and I was like, "What are you talking about?"
Right.
That totally makes sense.
Yeah. So it's very common for people to get tackled like on the football field and their knee collapses outwards, and they'll get what's called the terrible triad. They'll tear the MCL, the ACL, and the medial meniscus, which is a piece of cartilage inside the knee. And that's for a pro athlete, that can be it's likely a career injury because they'll be able to walk and stuff just fine after surgery and a lot of work, but they'll never be able to perform at that high level. They're not going to be LeBron anymore, right? They'll get a great job sitting at that big desk criticizing other players.
Yep.
Okay.
That's what they weigh their whole lives.
Okay, so moving on to patellar complex. Right here, my thumbs are nice and straight, and I'm just frictioning straight up from the patella. This is the patellar tendon. Yes. I can do the same thing below. I can feel tibial tuberosity. I'm going straight up to the patella. This is the patellar ligament. Yeah. But, we talk about fascia never really stops. It comes off the periosteum of the tibial tuberosity, becomes the patellar ligament, wraps around the patella, almost becoming periosteum again. Then it becomes the patellar tendon, which then attaches to the muscles and becomes the epimysium. Okay, so the fascia just continues on and on and on. Well, we just did above and below. We kind of ignored the patella. The key with the patella, we only ever want to move it up and down. Whenever your knee's moving, it's moving up and down continuously. It's got these nice grooves in the back. Think about it like a record player. We don't want those grooves to get wobbly. People get patellar wobble. It can lead to patellar dislocation. So we want to always have the knee going up and down. So what I'll do is I will use the web of my hand to pull down the skin and secure the patella. Now the patella can't move side to side. And I'll go down with my pincer grip and friction around the edges of the patella. So I'm working the fascia around the kneecap. Then I'll use my other web, pull up and secure the kneecap. You can see it really well there. See, it can't go side to side, I've got it secured, and I can work around the bottom edges of it.
What about people with further, like, history of knee injuries? Is this still?
Right, they probably need it.
Just curious.
On our slides, it does talk about if you have somebody who's scheduled for an upcoming knee surgery, they need to consult with their doctor.
Right.
Okay. I'm going to go ahead and move on to, there's one more for the knee. For this one, whenever we're going to move the thigh, we're going to do this twice. We're going to use for the knee and also the medial thigh. I make sure I've got my lateral drape here, nice and solid. Pull the drape from here and I roll it down. So I'm rolling it this direction, so it forms like a handlebar grip. Give that to my client. And so if she starts to feel the drape getting loose, she can roll it and it'll tighten up around her thigh. If it's getting too tight, she's losing blood, she can loosen it up a little bit. But now she's in control of making sure the drape stays nice and tight. In this position then, I can pop the knee and it stays nice and draped. Okay. When I'm going to do this, usually I'll just plant a glute on the edge of the table. I'm not on her foot, I'm just in front of the foot. That way it's not going to slide away. Then I get my 6 shooters out. My barrels go on the sides of the knee to go across the ligamentous structures, and my thumbs go tibial tuberosity, patellar ligament, patella, patellar tendon.
It's kind of like you're getting every bit of it.
Mm-hmm. So I don't know why a lot of my anatomy, hands-on stuff is associated with guns.
There have been a few
We're good.
That's how I remember. Yes, that's the only reason why.
There's that one.
So we've done 2 upper attachments, ASIS for sartorius, AIAS for rectus. We've done the entire patellar complex. Sartorius does come down over in front of the thigh, behind the knee, wraps back around the tibial tuberosity. So you guys palpated that earlier. Under your kneecap, you can find your tibial tuberosity. Curve my fingers for strength. Follow up around, there's a natural curve coming around this medial side of the knee. That's going to give me access to working 3 tendons. You've covered all 3 of them now. From the back side, we had which hamstring? So my tendinosus. From the medial side, the slender muscle. Gracilis. And from the anterior front, we get sartorius. So working here, tracing that natural curve around for them. Then, in this position, I can do it. I can also rotate the thigh out as long as my drape stays good. But I'll come right here at the back of the knee, and palmar glide up to the ASIS. So back of the knee, up to the ASIS. Okay, that's my sartorius line. All right, let's see if we can see the quads. Can I be kicked towards the ceiling? Nice. Look here, we can see vastus lateralis, a little bit of medialis right here. Just see, you can really see the latissimus teardrop, and then rectus is starting right about here. So sometimes it depends on Thank you. Depends on muscle mass, depends on body fat, depends if they know what you mean by kick the ceiling, whether or not you can see any or all the 3 heads of the muscle. The nice thing is when I find rectus femoris, I can go ahead and pincer palpate it, and then I can move it. Remember when we did the bicep? We had to identify bicep, we moved it aside to go into brachialis behind it.
Yes.
Same thing here, we're going to pincer palpate rectus femoris. And again, if you're not sure, you can kind of get position, have her kick for a moment, and you can right there grab it. Okay? Then we can shift it to the side, and you always start in the center of the thigh. It's attached at the top and the bottom. That means it's less mobile. If I start in the center, I can get in there easier, then I can work towards the ends.
So I kind of getting like the edge of it a little bit and moving it over with your thumb.
Uh-huh. So there it is. I'm just moving it to the side, and then I can work in behind it. I'm not doing a big, long, deep glide, so I'm not that worried about the direction of flow. I only get a couple of inches inferiorly.
It's effective.
That means it feels great.
Yep, it looks like it.
Also, I find I can get in easier on the medial side than on the lateral side. So that's vastus intermedius. Okay. Now, when you did see those teardrops, common trigger point locations are right in the center of that teardrop, especially on the medial side. Right there. And I always think back, sorry, this is dated reference from the 80s. People grab your knee right there, like, oh, and they're like, Allison likes boys.
You like girls?
Right, that little thing.
Yeah.
So, it's or Allison has trigger points, okay? So, that's right there you go.